Good morning and welcome to another episode of WSU Talks for Nurses. My name is Mikayla Muscat and today we will explore what it means to live with a severe and disabling psychiatric disorder known as obsessive compulsive disorder. Throughout this presentation today, we will discuss information about how the person living with obsessive compulsive disorder may present to services, the symptoms they may complain of and how these symptoms affect their daily life, an overview of the challenges they may face, the incidence of this mental health issue within Australia, a description of relevant recovery-focused nursing interventions to assess the needs of the person and assist the person as well as their family in understanding the condition, whilst developing effective strategies to support the person's recovery. Finally, we'll discuss an outline of one current Australian service initiative designed to improve care and reduce the impact of obsessive compulsive disorder. Obsessive compulsive disorder is often misunderstood, or better yet, stereotypically incorrectly described as a disorder associated with general neat, orderly, or fictitious behaviours. Though this generalisation may be correct when describing the disorder for few clients, obsessive compulsive disorder is more appropriately defined as a severe and disabling psychiatric disorder that presents with several challenges due to obsessive, intrusive, and anxiety-provoking thoughts and compulsive, repetitive behaviours. I know what you're thinking. Everyone has experienced irresistible urges or intrusive thoughts at least once in their lifetime. So what separates people living with obsessive compulsive disorder from those living without the disorder? Well, according to the University of Cambridge, a diagnosis of obsessive compulsive disorder, OCD, is made when these tendencies become excessive and life disrupting in the form of obsessions and compulsions. Obsessions and compulsions are said to be the most common symptoms of OCD. So what do these thoughts and behaviours look like and how do they affect daily life? Let's have a look. One of the most common obsessions seen is fear of contamination due to germs. This obsession triggers the compulsive behaviours of excessive cleaning, hand washing and showering, which may lead to dermatitis of the hands. Another example is fear of hurting others or inflicting accidental danger to themselves. This obsession again will lead to compulsions of possibly checking taps, locks, and electrical switches in fear of damage or harm. Now, to put this example into perspective, an individual with OCD who has finished using a portable heater may check if they have switched off the machine several times in fear they will burn down the house. Preoccupation with having things in order or following certain patterns is also seen in OCD. Symptoms of this behaviour is hair pulling, skin picking, hoarding random objects, for example, bread clips or old newspapers, are commonly associated with this obsession. Anyone seeking addiction recovery typically faces numerous emotional and mental frustrations. They have increased problems focusing on treatment components and are more easily distracted due to intrusive thoughts and behaviours. According to Mental Health Centre, getting out of the door to leave for work by 9 may be a job in itself for a client suffering with OCD. People with OCD are usually aware of their behaviours and know they are excessive. This can be embarrassing for the client, forcing them to keep their condition a secret, preventing them from seeking help. People who suffer from OCD are more likely to develop depression or additional anxiety disorders. It is the obsessive nature of the behaviour/compulsion in which tends to lead to additional anxiety disorders, such as body dysmorphic disorder, trichotillomania, hypochondriasis, compulsive hoarding, anorexia nervosa, panic disorder, and social anxiety. As we have established, there are a variety of symptoms involved in OCD, all of which have a tendency to affect daily life, as the compulsions and obsessions can take considerable time. Okay, now we have established the foundations of OCD, let us have a look at the statistical side of this disorder. In Australia, approximately 3% of people experience OCD in their lifetime. This equates to more than 500,000 people. OCD can occur at any time during life. In fact, children as young as 7 or even 6 may present with symptoms. Despite this, symptoms tend to develop fully for the first time in adolescence. According to Beyond Blue, evidence suggests that many people with OCD will present subclinical symptoms years before the development of their disorder. Without proper treatment, OCD can be a chronic condition. Studies recorded prior to the COVID-19 pandemic suggests $10.6 billion was spent on mental health in Australia. Of that figure, 2% accounts for the economic cost of OCD. Now, I specifically raised the fact that these statistics were developed prior to the COVID-19 pandemic, as a journal article published by the Psychiatric Research suggests the containment measures implemented to reduce the progression of COVID-19 can increase the risk of OCD. The fear of getting infected and the importance given to personal hygiene may create a negative impact on this clinical population. Okay, as nurses, we can all appreciate understanding the barriers to treatment and knowing what to expect ahead of time are extremely important to successful treatment for both the family and the individual. Now, according to the International OCD Foundation, the most effective treatments for OCD are a type of cognitive behaviour therapy called exposure and response prevention, ERP, and or a class of medications called serotonin reuptake inhibitors, or SRIs. But as nurses, what are some of the interventions we can put in place to aim to aid recovery and assistance? Of course, there is the administration of medications and providing assistance during ERP therapy. But in addition to these strategies, what as nurses can we do? I will explain this by listing interventions and then explaining the rationale behind these interventions. Our first intervention is establishing a therapeutic relationship through the use of qualities such as empathy and respect. We need to demonstrate interest into the client. Establishing trust provides support and communicates that the nurse accepts the client as a person. Verbalize empathy towards the client's experience rather than disapproval or criticism. Moving on to the next intervention, we need to acknowledge the behaviour without focusing attention on it. We also need to educate the family to do the same. Lack of attention to the ritualistic behaviours can diminish them. Reflecting the client's feelings may reduce the intensity of the ritualistic behaviour. For example, you may say something like this: I have seen you switch that electrical appliance off 3 times today. That must be exhausting for you. Maybe try doing it once. Moving on to the next intervention, we need to use a relaxed manner with the client. Keep the environment calm. Again, we also need to educate the family to do the same. Any attempts to decrease stress will help the client to feel less anxious. This is especially important when the client is at home, as it should be considered a safe space. Moving on to the next intervention, we need to assist the client in learning stress management. This can include things such as participating in arts and crafts and sports, as it takes the concentration away from the ritualistic behaviours. Moving on to the next intervention, we need to encourage the client to explore the meaning and purpose of these behaviours. Ask them to describe the feelings when they experience these behaviours, whilst examining the precipitating factors. Again, we need to encourage the client to voice these thoughts to the family or supportive teams around them. This poses as an opportunity to understand the process and gain control over the obsessive compulsive sequence. Recognizing precipitating factors allows the client to interrupt escalating anxiety. The last intervention I would probably recommend is discussing the at-home situation. As I mentioned before, the home needs to be considered a safe place. Returning to an unchanged home environment will increase the risk that the client will resume compulsive behaviours. As we are drawing to a conclusion, I would finally like to outline one Australian initiative designed to improve care and reduce the impact of OCD. The Anxiety Recovery Centre Victoria is an Australian specialist mental health organisation providing support, rehabilitation and informative services to people and families living with anxiety disorders. They aim to support and provide people with knowledge and skills to build resilience and recovery and reduce anxiety disorders. They have developed an OCD and anxiety helpline, which relay advice and support and connect clients with other community resources such as support groups available for both family and friends in similar situations. Now, the helpline team are provided with training and ongoing support and supervision by the helpline coordinator. The role of the voluntary telephone support team is to identify problems and barriers to recovery, assist callers in understanding and managing symptoms of anxiety disorders and depression, assist in helping more effectively deal with the impact of their condition on the family and relationships around them, and also to develop self-management skills. That concludes another episode of WSU Talks with Nurses. I hope you enjoyed learning all about OCD, the signs and symptoms, the incidence in Australia, as well as the strategies we as nurses can do to assist in the recovery of OCD. Thank you for your time today.